Principles of Pediatric IV Fluid Therapy. Be aware that many prescribed medications frequently will contain considerable amounts of electrolytes. So again, the younger the child, the greater the risk of electrolyte imbalance. A young child has a larger body surface in relation to weight, resulting in greater fluid losses than the adult. Pediatric metabolic rate is about 3 times faster than in an adult, which increases water requirements greatly. Pediatric patients have a tendency to develop metabolic acidosis. Insertion of IV cannulas should be performed in treatment rooms. This will allow the child to associate their bed in their room with comfort and security and not unpleasant procedures. Use age-appropriate distractions to help take the child's mind off of the procedure. Topical anesthetics must be in place for approximately an hour for full effect. The thing about topical anesthetics is they can cause vasoconstriction. So with vasoconstriction, it may make accessing an IV or a vein more difficult. There is also oral high sucrose solution that can be very effective in infants. So that may also be another type of pain relief that you could use. Do not allow the child to see your equipment, if possible, prior to the actual procedure. So you should prepare your equipment outside of the room. Be honest with the child. Make sure the child knows that the needle is removed. A lot of kids just really freak out thinking that they have a needle in their arm, that it's not coming out. They need to know that it's just a little plastic catheter that will be left. Tell the child why the procedure is necessary in terms that the child is going to understand. Do not tell the child that the procedure is not going to hurt. Rather, tell them that it will hurt a little bit, but that you'll be as quick as possible. Always have at least one other staff available to help restrain the child, and usually you'll have that staff member restrain above and below the potential insertion site. When you start IVs on pediatric patients, you frequently have to hit a moving target, so be prepared because the child will often move despite restraints. It is not recommended to have the parent help restrain. Rather, allow the parent to be the one to provide comfort. After the procedure, be sure to praise the child's behavior regardless of how cooperative the child was, and allow the child to talk or play out feelings if necessary. The different sites that you want to look at with your peripheral veins, you've got your dorsal hand veins that can be used for all ages. You need to avoid using the dominant hand or a thumb-sucking hand if possible. It frequently will require splinting on an arm board, and it can interfere with the child's activity level. You can look at the dorsal foot veins in a child that is not walking. You may need only the grasp of an assistant around an extremity instead of using a tourniquet. Again, immobilize the extremity with a padded board, but make sure that you position it in a manner that maintains normal joint configuration. These peripheral veins can be used in pediatric patients up to the walking age, occasionally for older children in cases of trauma or burns. Those will be the foot veins. The antecubital fossa is generally not a recommended site because of the need for immobilization, but it can be more favorable in the older child. And again, try and use the non-dominant extremity when possible. Make certain that you avoid the inner aspect of the wrist because infiltration of this area can result in dangerous traumatic pressure on the radial artery and the radial nerve. Scalp veins are readily available up to approximately 12 to 18 months of age. The most commonly used scalp veins will be the superficial temporal, the frontal, the occipital, and the preauricular. To dilate these veins, you can place the head lower than the rest of the body, which usually causes crying. Crying along with the lowered head will help raise the scalp veins. But it's difficult to distinguish veins from arteries in the scalp. LPNs cannot perform scalp venipuncture. Scalp IVs can create psychological distress for parents because of the misguided belief that the IV is in the brain. An IV site has to be well protected in the scalp to prevent dislodgement. But they are no longer considered the first choice in infant care. And central veins. You have the percutaneous central venous catheters that can be placed in jugular veins in neonates and infants, subclavian veins in older children, and occasionally femoral veins. And the peripherally inserted central catheters, or the PICC lines. These go into the basilic, median, cubital, and cephalic veins of the antecubital fossa. Neonates and small infants, excuse me, you use the large saphenous, superficial temporal, external jugular, popliteal, and axillary veins.